Welcome to Prescribe Already. It's your host Shatner.
Just saying you did the last one. That's all I'm saying. Just saying.
It doesn't matter. We don't know what order this is going up at.
I'm Chris. I'm clearly the second best host in this.
Yeah.
This
Well,
morning.
that's fun. That's a fact.
Absolute narcissist over here.
So today we're going to be discussing about endometriosis. Well, not discussing. We're going to be learning about endometriosis.
Well, learn and discuss.
Yeah. So kick back, relax, and enjoy this soothing podcast
of us talking rubbish about a topic that we haven't learned yet. So yeah, enjoy learning with us.
Enjoy learning with us. So endometriosis. What is endometriosis, Chris?
It is the presence and growth of endometrial tissue outside of the sort of endometrium.
Okay. And
outside the uterus, basically. So, and it's most common in nulliparous women. So,
which means what exactly?
They have not had any pregnancies.
Any pregnancies? Okay, cool. And how common would you say endometriosis is?
It's like I think 1% between the ages of like 15 and 45 of women will get it. So one in 100 chance if you're that age.
Okay. Well, like less than 1%, probably.
Sure.
What
does it say? It says less than 1%.
Yeah.
You read it?
Yeah, I did.
Cheater.
And
put me on the spot. Maybe trying to remember.
Usually, women in their 30s are.
That's where they typically,
more at risk. Yeah. And like you said, nulliparous. That's a risk as well.
Yeah, and then there's also a probable chance of like a familial predisposition to it as well. Yeah.
So, do you understand endometriosis? It's not imperative. Like, it's a good to know the pathology behind it.
Yeah, and like the underlying physiology of the basic anatomy and things like that.
So the main hormone which drives endometriosis is estrogen.
Yeah.
So therefore it affects women of reproductive age.
Because you have your rise and fall of your hormones.
Yeah. So
how does it present?
The pathology.
Oh. Are we doing pathology?
Well, like it's pretty much it's just a one sentence thing. Okay. Endometriosis pretty much causes inflammations with progressive fibrosis and adhesions.
Okay.
I'm not going to discuss like the cells involved and everything like that because that's.
No. So it's basically just endometrial tissue pops up around the sort of
it can
the abdominal organs, your sort of bladder can be on the outside of the uterus, can be wherever, and then this cyclical change of your hormones, of your estrogen, causes the symptoms of endometriosis.
Yeah.
Would that sound?
That sounds fabulous. Like that's well thought and well strung for someone who's not like interested in pathology.
It's
fantastic. Yeah. So the three main theories around endometriosis is like retrograde menstruation, which means what's retrograde?
Lad,
it doesn't matter.
I didn't want to go into
this. So like pretty much it's just retrograde menstruation. Search it up if you don't know what it means, and leading to adherence, invasion, and growth of tissue, and metaplasia of the mesothelial cells, and it explains why it can develop in the lungs and nasal cavity. And impaired immunity is also another theory they have. Endometrial cells from the retrograde menstruation fail to be destroyed by the immune system. So these are the theories surrounding endometriosis on why it happens. Correct me if I'm right. They don't know why, like what the cost of it is.
Not like properly. We just know that estrogen kind of drives all these symptoms.
These are the three main theories. So retrograde menstruation, metaplasia of mesothelial cells, and impaired immunity.
I've looked up what retrograde menstruation is.
It's just a normal menstruation.
It is when menstruation, like the blood of menstruation, goes backwards up.
Oh,
the sort of, fallopian tubes.
Okay, and why would that happen?
And like into the ovaries and the other sort of pelvic sort of tissues. And that's what's causing the sort of endometrial tissues getting there. I don't know how that would happen, to be honest. Maybe an imperfect hymen. I don't know.
That sounds. That sounds.
If you've got a clog in a pipe, it's gonna go the only other way it can go, which is back up.
Yeah. And on examination, can there be anything seen?
So it can be normal and minimal disease, but if you get a speculum, you may see sort of visible lesions on the in the vagina or the cervix,
but is that not sort of rare and sign of like a deep
that would
deep
show
infiltrating
that
endometriosis?
there's like more severe sort of endometriosis going on.
Okay.
On a bimanual examination, you would find that there's a fixed retroverted uterus. Which is like a classic sign. So if you see that in a question,
fixed retroverted uterus,
you're going to be thinking about endometriosis.
Yeah. And like the most gold standard investigation for endometriosis is the laparoscope. Yeah.
Laparoscopy with biopsy and a tubal dye test.
So where you're dyeing the tubes.
Aye, so I think that you're putting the dye within the tubes, and it must be that this sort of endometrial tissue attracts the dye and keeps a hold of it. So what you would see would be there would be active lesions on the peritoneum. You may see white scars or brown spots, which is called the gunpowder sign, which shows a sort of less active endometriosis. And then if you see sort of an extensive amount of adhesions and cysts, it also sort of points towards a diagnosis of endometriosis.
Extensive adhesions, okay.
Yeah.
And okay, that's interesting. And ovarian endometriomas is chocolate cysts. That's what they call it.
Oh.
Just trying to remember. It's like
ovarian endometriomas. Okay.
So it's just like it just looks like chocolate, realistically.
Chocolate cysts. Okay. So you also want to do other investigations along with this. So you would like to do your TBS, your MRI, and your CA-125. So your CA-125 to check out if there's any sort of ovarian cancer.
Yeah.
And MRI, it's a good way of scanning the surrounding tissue, because you have these signs and symptoms, which we will get to.
Yeah. But you just need to remember you can't diagnose endometriosis with CA-125 or an MRI.
Yes. Yeah. It's not diagnosis by that. Yeah.
So okay.
They're to rule out other diagnoses.
Yeah.
So then move.
We forgot to mention the symptoms. This is one of the biggest things.
Yeah. So biggest one is pain. Which,
so,
since it's due to hormones, then is going to be cyclical with
pain.
The normal menstrual cycle.
Yeah. And also in some, or is it mainly like all of them, all women who's experiencing endometriosis get deep dyspareunia. It's pretty much pain whenever you're having sex.
Yeah.
So that's only due to the involvement of the uterosacral ligament, which
so if there's endometrial tissue on the uterosacral ligament, that's when you would get your deep dyspareunia. Other sort of symptoms you would get would be dysuria, so pain urinating. Dyschezia, which is pain when defecating. Dysmenorrhea, period pain.
And you can also get cyclical hematuria.
Right, yes.
That's due to the fact that like the deposits are near the umbilicus.
Yeah.
So it realistically you can have varied symptoms
depending on where that endometrial tissue is, like where it's gone to.
Got you.
That makes sense. Yeah.
And subfertility, which is expected from endometriosis, isn't it?
Yeah, it's inflammation. And like if it's say affecting your fallopian tubes and
it's not infertility, it's subfertility. So you're less likely, but can still
yeah.
Yeah.
With medical management, of course.
Yeah.
Which I think we're getting to now, aren't we?
We're getting on to the 5 initial managements for endometriosis.
Excellent. So starting off, we're dealing with pain. So you're thinking of painkillers. So your
Yeah.
NSAIDs and your paracetamol.
The first line. So first line pain management ladder. So just follow that.
Yeah, and then if sort of you're wanting to prevent this sort of pain going on, you can use the combined oral contraceptive pill.
So like we mentioned before, it's very estrogen dependent.
Mm-hmm.
So like realistically using COCP.
If you're stopping the normal cycle,
like it does help.
Yeah, then that's if there's no more cyclical change to the hormones, then there's not going to be any more sort of periods, and therefore the endometrial tissue isn't going to get all angry and cause all these symptoms. So and then what's after the COCP?
So there's danazol, which inhibits the gonadotropin hormone, which is like it works as an anti-estrogenic and progestogenic and androgenic activity. Okay. So
it's just higher up in that hypothalamic sort of pituitary tract, isn't it? Like
pretty much any medication used other than the pain medication is to target the hormones,
prevent estrogen.
Yeah. So progestogen is also used,
which is different from progesterone.
Yeah. So it's a steroid hormone. Okay. And like the side effects just with any sort of steroid hormones.
Your weight gain, fluid retention,
premenstrual syndrome.
That can actually be quite severe in some patients. Okay.
Yeah.
Right.
And your gonadotropin releasing hormone analogues, which is goserelin, which was
Groserelin,
not goserelin. I always go goserelin. So if you think about it, it induces a menopausal state. So you're like, if you're young, you're growing groserelin. That works.
No, that is so ridiculously stupid. I actually think that would work.
Yeah, because you're growing into a lady, into an older woman. Yeah, that works. Groserelin. Serelin is an old lady.
Serelin is growing old from gonadotropin releasing hormone analogs.
Totally works.
That's that.
Bang.
Aren't you guys so lucky to have us, making up all these learning mechanisms? So
and Mirena.
The Mirena coil, yeah. I mean, that's another, that's your similar sort of idea as the COCP for preventing menstrual cycles.
Yep.
You can also use surgical management for endometriosis. And this is really indicated after sort of all this medical management has failed.
Yeah.
So one way is using diathermy. So you basically just burn away the endometrial tissue that shouldn't be there.
Yeah. Okay.
Another one is quite drastic. You would do a hysterectomy with a bilateral self-ping oophorectomy. So let's break that down a wee bit. So hysterectomy, removal of the uterus.
Yep.
And sometimes the cervix, isn't it? Or that's radical.
That's radical.
So removal of the uterus, and then bilateral salping oophorectomy.
That's your ovaries. Oophorectomy is your ovaries, and salpingio
is your
fallopian tubes.
So bilateral meaning both sides.
So you're pretty much taking everything out apart from.
So you wouldn't use this if someone was wanting to have kids in the future. Yeah.
But I think this is like the last line.
Real last line type of stuff. Yeah.
Yeah. Okay. Yeah. So if a patient with endometriosis, starts to develop a heavy, painful period, the most likely cause would be adenomyosis,
which is when endometriosis spreads.
Yeah.
So it gets to the myometrium. Correct.
Yes, adenomyosis. Yeah.
So it gets to the myometrium, which is your outer layers of the uterus. So we'll get the editor to whack a wee diagram up here because he loves his job of doing editing.
Yeah. So diagram
big diagram here
of a uterus.
Yeah.
And
with each of the layers.
Each of the layers labeled. Endometriosis, like I said, can affect fertility by subfertility. Well, it's pretty much subfertility.
Yeah.
Due to adhesions and cytokines.
Okay.
So with the inflammation happening, cytokines are inevitable.
Yeah.
So yeah.
Yeah, if there's inflammation going on in that area, it's not going to help
Yeah.
the oocyte, and it's going to disrupt tubal
The
function
fertilization,
and fertilization in general. And the same with adhesions, they're altering the sort of function of the tubes and ovaries.
Yeah.
Because if you think about it, if you have this sort of tube that's all gunged up and messed up, it's going to be difficult for something to get down that tube.
Yeah. So
and up that tube inversely.
Yeah. Yeah. I think that covers quite a lot of endometriosis, and that's probably us for today. It's been
it's been a good day of podcasting.
Good day's podcast. Yeah. Hope you enjoy our session on
endometriosis, and like, comment, subscribe, follow,
any
sort
of comment, everything. So
we want to get this out there so that us medical students can also revise together, have a bit of a kinship.
Bit of a crack.
Yeah.
This is only
symbiosis.
For a bit of a crack. All about symbiosis.
Yes.
Yeah, that's it for today. And if you're listening to it on the podcast, feel free to check out the video on YouTube.
Yeah,
because it's pretty cool. We'll be doing
funnier
stuff.
Yeah, we'll start doing like questions and things like that.
Yeah, funner stuff alongside if we get. It's not fun, but you know what I mean. If we do rack up a good following, you can just go with it. This is just us for learning and enjoying.
Aye, exactly.
That's it for today.
Making learning fun.
Yes, sir.
See you guys.
Bye.